So what are the treatment options then? We've talked about screening, we've talked about precision diagnosis. Let's come on to treatment options. And I'm going to concentrate on localized prostate cancer. So I know some of you may unfortunately have metastatic prostate cancer and so on, but these treatments that I'm talking about is when it's still localized within the prostate gland. Broadly speaking, we categorize prostate cancer into localized staging, i.e. nothing outside of the prostate, into locally advanced staging, where it might have just gone outside the capsule, it might have gone in through the back in the seminal vesicle, or it might just be involving a very early local lymph node. That is locally advanced. And then metastatic or advanced prostate cancer is where sadly it has spread beyond the confines of the capsule into either the bones or distant lymph nodes and so on. Okay, so we're talking about localized treatment now. The radical treatment options are there listed above. Radical prostatectomy, which has evolved a lot over the years. When I first started out, I was doing open radical prostatectomies. Now there are few and far between carried out open, and the vast majority are carried out through the Da Vinci robot system. Radiotherapy, and there are two types of radiotherapy: the external radiotherapy given from the outside of the body to the prostate, and the internal type, whereby or otherwise known as brachytherapy, where radiation seeds are implanted into the prostate. All of those treatments, those four that I've listed up there, are what we call whole gland treatments. So regardless of where the prostate cancer is, the whole gland is either removed, or the whole gland is either irradiated, or the whole gland has brachytherapy seeds inserted. And then we come on to the focal therapies, which I'll allude to more later. And of course, there is active surveillance as well. Okay, very important option nowadays for early, low-grade, low-risk prostate cancer. These are just a slide of some of the side effects that sadly can occur with radical whole gland treatments. And these are with radical prostatectomy and radiotherapy. We know that there is a significant risk of urinary incontinence. The figure that we quote is about 10% at 1 year. In some cases, it's higher than that. In many cases, it's lower than that. And again, that it can be surgeon related. The risk with radiotherapy should be very low. You're not cutting anything, and therefore your risk of urinary incontinence should be low. Erectile dysfunction sadly occurs with both of these treatments. There's the risk quoted there, 40 to 60% for radical prostatectomy. The NHS website regarding radical prostatectomy quotes a figure of about 50%. And it all depends on whether your surgeon can nerve spare or not nerve spare. If he can't spare the nerves on either side of the prostate, then your risk will be 100%. Bowel symptoms are obviously rare in radical prostatectomy, but do occur with radiotherapy, and I mean diarrhea and bleeding from the rectum. Usually short-lived for a few months, and then it can settle down, but there's some people who are troubled by this long-term. Fatigue is very common with radiotherapy. It's usually a long treatment and so on, and can last for a while. Decision regret is also an important factor. There are several tools now to assess decision regret analysis, and we know that in radical prostatectomy, about 30 to 40% of people do suggest that they regretted their decision of having had the radical prostatectomy. Even after a radical whole gland treatment, it can come back, sadly. Prostate cancer is a little bit like breast cancer, that unfortunately there are a lot of possibilities of it coming back. So a lot of patients don't perhaps understand that even after you've had the whole prostate removed, that it can still come back. And the studies suggest that at 15 years, there are significant biochemical recurrence rates for both radical prostatectomy and radiotherapy. It does depend upon your risk grade categorization of the cancer, and that relates to PSA, the Gleason grade, how aggressive the cancer is, and so on. But you will see that, for example, in the left-hand graph, the top bar is for high-risk cancers, the middle is the intermediate risk cancers, and the light blue line is low-risk cancers. So you can see that even after a radical prostatectomy and radiotherapy, prostate cancer can return. This is a paper that came from one of our institutions, whereby they studied decision regret analyses. And this was published 4 or 5 years ago. And they showed in a high volume center where we do lots and lots of radical prostatectomy, 30% of men reported high levels of decision regret. And the regret, as you can understand, was related to the side effects, urinary incontinence being a primary one, erectile dysfunction, and also a lack of counselling and information at the time of the decision. So counselling and shared decision making is absolutely vital in determining what treatment you would like to have. And this goes for all of us, that we feel that obviously preoperative education is important, that we speak to our patients openly and transparently about the treatment options and what they may or may not expect.